Hey, good evening, everyone. Tonight's Instagram Live is with Shaun Rotenberg, periodontist in Ohio. Let me invite him to join us here. Hey,
Hey
so
Shane,
how are you?
good. How are you?
Good. I always love when technology works how it's supposed to.
I know. It's great.
Hey guys, well, I see that we've got some people starting to join us here tonight with a 30-minute discussion with Dr. Shaun Rotenberg, periodontist and someone that we've been working with at Osteogenics now for, I want to say maybe 5 or 6 years. Um, and by the way, I'm Shane Shuttlesworth, president of Osteogenics. I always get in trouble for not introducing myself. Hey, I appreciate your time and joining us. And for the audience, if you guys have any questions, we'd love to get your questions answered. Ideally, this would just be a 30-minute Q&A session with you guys. In the meantime, I do have some questions that I've kind of prepared to kick off some discussion. But you can ask questions via the little question mark symbol there in the bottom right, or you can put it in the chat, and I'll try to keep an eye on that. So jumping into some discussions. I think the first time that I found out about you was when our founder, Dr. Barry Barty, attended a lecture. I want to say at the Perio meeting. I can't remember what year that was, but it was on aesthetic ridge preservation, and it was using our dense PTFE membrane. And he came back to our booth, very excited, gave me your contact info, and said, "Hey, we got to get this guy at our next symposium." And that particular application was basically using the dense PTFE membranes in the interior, but you had a different angle to it than I think other speakers had in the before, and it was around basically using it for aesthetic ridge preservation. Could you talk a little bit about how aesthetics play into it and how you use that from like a soft tissue and aesthetic standpoint using that technique?
Well, back then that was probably 5, 6 years ago when I gave that presentation. But and I've kind of taken that technique and continue with it, and shown that basically by leaving the TXTs exposed, and not needing to get primary closure, you really can increase the amount of keratinized tissue you get. You don't change the mucogingival junction position. So you're really able to kind of truly preserve the aesthetics that are there. A lot of times I find that, especially when we're rebuilding bone, sometimes we sacrifice soft tissue aesthetics by doing it, and especially in the anterior. Everyone wants to get an implant there, but if it means sacrificing the aesthetics, be that papilla, keratinized tissue, tissue thickness, mucogingival junction position, that sometimes can be too big of a trade-off.
Yeah, gotcha. Do you use that technique in the posterior too?
Yeah, I do. I do. It works great in the posterior.
Okay.
Maxillary first molar that's got recession almost to the apex. I'll leave the TXT exposed, remove it 4 to 6 weeks after I place it, and all that tissue, that immature tissue that we see, turns into keratinized tissue, and then the underlying bone turns into normal bone.
Yeah.
So
What if you're missing one to two walls of the socket? Do you do anything differently?
I've used this technique, where I've lost the entire buccal wall. I've used it where I've lost a buccal and a lingual wall, still with good success. Anything I do at the time of extraction, really, I don't flap anything at the time of extraction. The only time I'll ever flap something at the time of extraction, especially in the anterior, is if I just can't get proper degranulation. That's the only reason. To be able to place my membrane, I'm going to do it without any sort of flap. I'm going to place the membrane through the socket. Um, and I've actually kind of gone back to, if, instead of creating a full thickness flap, and releasing papilla, I'll sometimes, if I have to get better degranulation, I'll actually create a vestibular incision, just to ensure that I don't have to touch the papilla, and I don't have to, you know, you know, you know, potentially affect the aesthetics.
Okay. So do you just create like a pouch between the periosteum and the buccal wall or the lingual wall for the membrane to slide in?
Yeah, so I just create a pouch that's typically about 2 millimeters over the bony wall, the bony border of the defect that I have, and I tuck my membrane just like I'd be tucking in a soft tissue graft.
Okay. What about graft material? What graft material do you use for ridge preservation?
I am very basic. I'll just use just freeze dried bone allograft, FTBA, cortical, not cortical cancel. It's just cortical.
100% cortical.
Mhm.
I like it. Yeah, that's definitely it keeps it simple.
Yeah,
Um,
but again, back to I think the reason why I can use that in situations using the TXT is because at the end of the day, socket reconstruction and all bone grafting is just about graft containment and clot stabilization.
yeah.
I really think that if especially, if you can manage the space underneath a DPTFE membrane, I don't think the graft material matters as much.
Yeah. Gotcha. Um, and how long are you waiting on those sites? Are you waiting like
Normally 3 or 4 weeks, on average, 3 to 4 weeks if I'm missing a buccal plate. If it's a larger defect, I'll wait more toward like 6 weeks. Now, if it's a blown out defect, some of the ones I've shown where it's to the to the apex of the tooth, and I'm leaving the majority of that membrane exposed. Those sometimes I'll wait 8 to 12 weeks if I can.
okay. Um, okay, I'm gonna move on to soft tissue grafting. I know that's a topic that you're doing some lecturing and some teaching for us coming up. I want to talk a little bit about that.
Mhm.
And for those that have joined us since the intro, talking tonight with Dr. Shaun Rotenberg, periodontist from Ohio. If you guys have any questions, put them in the comment section or in the little question bubble, and we'll make sure that we get to those. We'd love to have your questions answered this evening. So you did a corporate forum for us, talking about kind of helping us launch a new soft tissue allograft product that we sell. I know you've been using it for a little bit over a year now, maybe.
Yeah, just about a
Um,
year. Yeah.
so could we start just with this topic? I think it's always good to start with, okay, autogenous versus allograft.
Mhm.
What's your philosophy? When are you using one versus the other? I think would be an interesting place to start.
Yeah, at the end of the day, autogenous is always the best. It's the gold standard. There's
Yeah.
there's many studies showing that. Um, the nice thing about autogenous, especially if you're doing a connective tissue graft, is great blending with the surrounding soft tissue that you have, and you still have the opportunity to get keratinized tissue by leaving some of it exposed. Now, the challenge occurs where either the patient comes in and says, "I refuse for you to go to my palate," or you just have to use autogenous on the patient would just be either too many surgeries or just too abusive to their palate, and that's where allografts soft tissue comes in, and that's how it is with my practice. I give patients all the options. I tell them what I would do if they were my brother or sister, and um, we make the decision together.
Gotcha. So what percentage of the time does that work out that you actually need the allograft?
I think we do a lot of soft tissue grafting. Out of the soft tissue grafting I do right now, probably 10-15% is allograft. Um, I think over the past year, it's been tracking up because of microderm, closer to maybe, I think it's on its way to about 20%,
Okay.
but still the majority is autogenous tissue. I think most periodontists are using autogenous tissue too, but again, the allograft is definitely indicated when you have a lot of teeth to treat or someone just doesn't want to go to the palate.
And why not use allograft for everything? I understand autogenous is the gold standard. Can we just talk a second about why it's the gold standard? Are we talking about like early healing? We're talking about tissue match, or we're talking about long-term stability, or we're talking about
Well,
thickness, or all of the
so with
above?
so with allograft, the long-term studies show that it doesn't hold up as well as your own tissue after about 10 years. If you look at if you look at the root coverage you achieve. But it's still good. It's still, again, when patients come to my office and I talk to I'm talking allograft versus autogenous, I say, look, where autogenous we'll get a grade of an A, still 10 years out, we'll probably have a B plus on if we use allograft. But the fact that we don't have to, if we're treating, let's say we're treating 7, 8 teeth at the same time, the fact that we don't have to do multiple surgeries, go to both sides of your palate,
Mhm.
it definitely, I think it's worth the con of potentially not holding up as well after 10 years. The other issue is aesthetics. With allograft, you have to cover it completely. You can't leave
Okay.
allograft exposed. Any allograft you leave exposed typically will necrose. It won't turn into keratinized tissue. So in the anterior, as far as aesthetics go, again, going back to what we were talking about with the TXTs, the fact that with an autogenous graft, I don't have to coronal position as much. Aesthetically, I'm probably going to get a better result. But sometimes in the posterior, most of the time I'm using allograft, canine and back. It's not as critical.
Okay. Got it. So the allograft the allograft product that we've launched is, what we think is novel about it is a micro surfaced on both sides. We basically put little cuts in it, and that allows it to soak up blood very quickly. It allows for uh, faster vascularization, is what we've seen. We've seen that in burn studies and adjacent sort of medical therapies, and generally also basically like cell invasion. And so that's what we like about it. And so that's how we kind of sell it, and that's why we think it's different. Can you talk a little bit about, I know you were one of the earlier folks to start using some of it. What has been your experience with it, and how is it similar to other allografts, and then maybe how is it different?
I think the biggest thing for me has just been patient experience with microderm. Um, a lot of patients who want allograft are coming in because they're afraid of postoperative discomfort from the palate, and they're very hesitant about anything surgical. Uh, what I've found with microderm is really it's very quick initial healing with less morbidity than traditional allograft. Patients are coming back much less, a lot less swelling, less pain. I did a case 3 weeks ago. I worked in 3 of the 4 quadrants in this lady's mouth, and she came back at the 2-week post-op and said, "Yeah, it wasn't that bad. I had very little swelling, not a lot of pain." And with traditional allograft, while I don't get much people coming back and say they have a lot of pain, they do get pretty swollen. So and then this is just my opinion. I've seen less swelling with microderm, but the biggest thing is the initial soft tissue healing. When they come back at 2 weeks, the tissue to me looks dramatically better than when I've used other allograft products. And I have great success with other allograft products. And don't get me wrong, allograft works. And if I look at my long-term results so far with microderm, 6 months out, even now a year out, and I compare them to other allograft products, they're very similar, but I'm getting much better initial healing. Patients are coming back much happier. The tissue looks better. And the biggest thing is I've had no necrosis yet. No patients come in with necrotic tissue, allograft tissue, which is kind of the norm. I always, in the past, I've told patients, I'm like, listen, if some of this gets exposed, it smells a little bit, it tastes a little funny, don't worry, that's normal. With this material, I haven't had that at all in all the cases I've done. And that's been great because it's a better patient experience. And a lot of these patients who are wanting allograft, just they want that better patient experience.
Gotcha. Let me help me understand the patient experience part, because I'm interested in this. I think this is a product and a procedure I'll probably need it in my future. Orthodontics and heavy brushing, I think has left me as a prime candidate at some point in my life. Like, what do you expect normally? Um, what do you tell your patients? What is the post-op protocol normally for these procedures, and has it changed at all?
So post-operatively for allograft, the thing with allograft is because it's devoid of cells. Yes, you're not going to the palate, so it's less overall morbidity for that patient. But because the allograft is devoid of cells, you're relying on your body to really infiltrate that allograft with its own cells to vascularize that somehow. So typically on a traditional allograft patient, they'll come back at 2 weeks. It's still, the tissue still kind of looks like it's healing. It's still a little bulbous. It's still, it's still got some inflammation there, which is good because that means healing's occurring. But really, I tell patients, 2 weeks, 4 weeks, you still have to be on a kind of a softer diet. You have to watch what you eat, up until about 8 weeks. Now with microderm, I just find that the healing's been much quicker. So, when they come in at 2 weeks, it looks like someone that I would normally have seen at like 4 to 6 weeks using another product. And because of that, I've been a little bit more lenient. Again, this is only my first year using the material, but I've been a little bit more lenient with brushing, with eating, with those microderm patients. I'll say, where maybe I would have waited 8 weeks for them to go back to a normal diet. Now they're back to a normal diet around 4 weeks. So and I haven't seen any complication with that.
Okay. Yeah, that's good information. Um, let's talk about technique, because I think whenever you did the corporate forum at the AAP lecture, as you were kind of showing some of your technique, what was interesting to me, we had a room of about 130 periodontists there, and about two-thirds of them had their phone out taking pictures and videos of your technique. And I don't think I had, this is an area of, I feel like I've been heavily involved in bone grafting for my 22 years in this business. And like soft tissue is something that's kind of always gone on, but maybe you probably didn't pay enough attention to it. And now that we have a soft tissue, we're kind of filling that portfolio gap. It's like, all right, I gotta learn a lot more about this, and it's really become super interesting to me. But the technique that you were doing, even to a periodontist, who I think are like the soft tissue grafting gurus, were taking pictures and videos of your technique, which to me tells me, okay, there's something here that's like interesting to the audience, or different, or new, or something that they want to better understand. So maybe just start off by talking about what is your technique for, and I believe this was mostly for tunneling, right? So it's like a
Right.
modified tunneling technique.
Right.
Can you tell us about that?
Yeah, so most people who use a good amount of allograft are using some sort of tunneling technique. They're typically not elevating papilla. And again, it's to increase blood flow to the graft and minimize flap and manipulation, and potentially compromise the blood supply to the flap. So I'm I don't do one specific procedure. If someone said, well, what technique do you use? I like to grab from a whole bunch of different techniques. I think I always use like the chef as a, as periodontists, as doctors, were like chefs. We don't just follow one cookbook. We study other people's cookbooks and then come up with our own recipes.
Yeah.
So I typically I use a lot of vestibular accesses to help create my tunnels. I find I'm able to do it much quicker. Anyone who's done a vestibular access anything, from a vista technique, a pinhole technique, they know that you can really create a whole create a whole recipient site in a very small amount of time. So I'll use a vestibular access to increase the speed at which I could create my recipient site. But the other thing too is because I'm not having to do everything through the sulcus, I'm really limiting the risk of tearing my flap or traumatizing my gingival margins, which ultimately are what I'm trying to improve. So I take a lot more force off the sulcus.
Okay, can you talk about the actual like incision design and
So the incision design, normally I'm creating sulcular incisions around the teeth in question, but I'm not reflecting any papillas. I'm not going all the way to the tip of the papilla. I'll typically reflect one papilla in that area, either mesial or distal of the the teeth that I'm working on, to be able to insert my graft.
Hmm.
Some people do insert their graft through the vestibular incision. To do that, you're going to have to make a bigger vestibular incision. Um, but the vestibular incision I typically do is a very, very small incision, typically 2 to 3 millimeters, in an apical coronal dimension, where I use a P. Charles periosteal elevator to do all my flap elevation, just to be able to get a very, very thin periosteal elevator in there to be able to create my recipient site. So what, basically, when I first insert my P. Charles, I'm in the mucosa, and I'm apical to the mucogenital junction. So I release everything apical to the mucogenital junction first, and then I work my way coronally up towards the gingival margin of the teeth. Once I get to that point, once I've reflected pretty much to the gingival margin, that's where I will now go through the sulcus with the periosteal elevator, just to be able to connect, all the areas, and I'll actually get up into the papilla area a little bit without actually severing the papilla.
Okay. Yeah, thanks for that detail. I'm trying to follow along.
I know it's hard
I
to
think
it's
I
it's
think
hard to
some
explain.
I think
It's hard to
some of
explain.
our audience members are probably following this a little closer than I am at this point, maybe. But
Yeah.
it's I know that there's a lot of interest around tunneling. Tunneling is
But it
some
but
sort of
but
yeah.
again, that's my technique. I think that ultimately everyone has their own technique that works best for them. I do think with allografts, you do have to make sure your allograft is covered completely. You have the most blood supply to it, and you're able to chronally advance there. And whatever way you do that, I think is great. I don't think my technique might be novel to some people, might not be novel to others, but I think the material itself, you can use it in different scenarios.
So I got a good question here. Any recommendations for vista access or choice of graft in the mandibular interior with a high frenum attachment?
Oh my gosh, this is where, my cojones are not as big as you might think. I'm very reluctant to do allograft in the mandibular anterior, because I will do a vista, like I will do a vista access for autogenous tissue, no problem. I do that all the time. Typically, if I'm treating 24 and 25, the central incisors, I'll elevate the papilla, especially we're going to do a Miller classification, Miller 1 or 2. I'll elevate the papilla between 23 and 24, between 25 and 26. I'll create a small vista incision. I'll tunnel. I'll release the freedom internally, and really release it, and then I'll slide my graft, through the papilla, and or through the access in the papilla until it reaches 24 and 25, and I'll suture. Now, again, I have a hard time using allograft in this area, because typically in the mandibular anterior, the reason why you're doing some sort of grafting is because of the lack of keratinized tissue. And if you don't have a lot of keratinized tissue to begin with, and that tissue is real thin, allograft isn't always the best choice. Now, have I used allograft in the mandibular anterior if I'm doing a full arch of allograft? I have, but again, you don't get the same type of increases in keratinized tissue that you would get with autogenous tissue.
Yeah.
So it wouldn't allograft is still definitely not my first choice for mandibular anterior.
Okay. Um, Question about the allograft that we sell is called the Cytoplast MicroDerm, the micro-surfaced allograft. Uh, it's not pre-treated with any antibiotics, so those
Mhm.
don't need to be rinsed out. I'm wondering, do you ever add any antibiotics to it,
Mm-mm.
or do you? And also, okay, so then I always ask this for bone, right? I always am interested in, do people mix like bone, like antibiotics with their bone graft in cases like with diseased teeth that are coming out? Like, so you're saying no on the mixing it with the graft. What about just putting your patients on it post-op? Are there any like
I do.
post-op?
I do put my patients on post-op antibiotics for allograft cases, for allograft soft tissue cases.
Okay.
The only time I use antibiotics in soft tissue is I do treat my roots with tetracycline, not for the antimicrobial properties, but more for it as an etchant on the root surface to remove the smear layer.
Okay.
There's studies to show that doesn't really make a big difference, but I do it.
Okay. Um, what antibiotic? I know that's the next question people ask.
For allograft soft
Yeah,
tissue,
like did you
I'll
put some
I'll
tape
use
on it?
either amoxicillin or a Z-Pak now because we can't use clindamycin. So
Okay, got it. Um, so I think the last couple of questions that I have, and I think there was one other question from earlier. I think uh, I think Dr. Warren Jones. I remember he had a question. He may have removed it, but it was around if you remove the membrane at 4 weeks. It might have been a little more nuanced than that, but I think you maybe eventually answered it. I was going back to the ridge preservation, the earlier part of
mhm.
our discussion. I want to. I think your practice. So you do a lot of soft tissue grafting. So you have like a referral based like soft tissue grafting practice. It seems to me just from discussions with you and other periodontists that maybe you even do more of this than like the average periodontist. And like, could you talk about a little bit about you practice with an oral surgeon, which I also think is interesting. And then you practice also with another specialist or
Well, we
just
have
tell us
no,
a
we
little bit
have
about your practice.
yeah. So we have two periodontists in my office. We have an
Okay.
associate periodontist, and then and me, and then my partner's an oral surgeon, and then we have a full-time anesthesia group that comes into our office. So we have yeah. So I guess if you want to call that a specialty, but we have anesthesia every day in our office with us.
So with an oral surgeon and a periodontist, where I think there's quite a bit of overlap, but also maybe some different areas of expertise. How do you guys decide when a patient shows up, who gets them?
Well, unless it's a specific, let's say it's jaw fracture, orthodontic, TMJ something. Obviously that's going to go to my partner or third molars. But if it's just an implant or so something implant related, we're my partner and I are friends enough where if it's something where I think he's going to be better at it, then he'll do it. And if it's something that I'm going to be better at, then he'll walk the patient down the hall and see me. And there's times where we're both going to have our strengths and we'll work on the case together.
Yeah.
I think it's just it's the whole all for one, one for all. We're there to help each other and whatever's best for the patient. That's
Yeah.
how we
Yeah.
decide who gets it.
I think that's great. And, I mean, it's kind of surprising. Like I just don't know I don't know. I don't, and I'm sure there are lots of others. I just don't know them, but I don't know a lot of like perio OMS like partnerships. But it would, I think it makes a lot of sense.
I love it. It's like I love going to work every day. So
Yeah. Awesome. Maybe the last question, last topic. So you're teaching a course in Mahwah, New Jersey this Saturday. I believe that's December 9th on kind of these advanced soft tissue grafting procedures. Some of the stuff that we talked about today, we're doing pig jaws. It's basically like for one day from 8 to 5.
mhm.
So if there's anyone in the audience that's interested in that, it's on Saturday. We know this is a busy time for practices, so we tried to do it on a time that wouldn't conflict with patient treatment. New York City and around Christmas time is nice. I know it's like my wife's favorite place to be this time of year. So maybe you could just talk a little bit about we talked a little bit about the procedures, but what will the attendees expect to learn?
Well,
Like didactic, there's hands-on.
yeah. So half the course is going to be on the socket reconstruction in the anterior. Half's going to be on soft tissue augmentation, focusing on microderm techniques or advanced tunneling techniques where we could use an allograft or even autogenous tissue. A lot of things that we're going to go over are indications for using the TXT 200 technique to expose it versus when you should try to get primary closure. How do you limit damage to aesthetic variables like papilla and keratinized tissue, things like that at the time of extraction. We're going to talk about extraction techniques for the soft tissue. For the allograft, we're going to talk a little bit more in detail because it's a novel product. How do you handle the material? How do you hydrate the material? Post-op protocols, things like that.
Awesome. We're really looking forward to that. I will be there myself, so I will see you on Saturday. For the rest of the group, I thanks everyone for joining us this evening and taking some time. And thank you, Dr. Rotenberg, for your time and your expertise. Really appreciate it and enjoyed catching up.
Yeah, thanks, Shane.
Okay,
I'll see you on Saturday.
see you soon. Bye.
Sounds good.